Welcome to our first video on bradyarrhythmias. Let's begin. In this lecture, we will talk about sinus bradycardia and sick sinus syndrome. For each of these conditions, we'll discuss the definition, causes, clinical presentation, diagnosis, and management. Let's start by talking about sinus bradycardia. Sinus bradycardia is the heart rate less than 60 beats per minute due to decreased rate of sinoatrial node depolarization. Let's talk about the causes of sinus bradycardia. Advanced age can decrease the rate of SA node depolarization, resulting in sinus bradycardia. Inferior myocardial infarction can also result in sinus bradycardia because it involves right coronary artery occlusion. Right coronary artery, on the other hand, is a major cause of blood supply to the SA node. Medications that inhibit SA node can also cause sinus bradycardia. These include beta blockers and non-dihydropyridine calcium channel blockers like verapamil and diltiazem. Hypothyroidism may cause decreased heart rate due to reduced sympathetic tone to the heart. High-endurance athletic training results in increased parasympathetic tone and therefore decreased heart rate at rest. Finally, any vagal maneuver can induce temporary sinus bradycardia because activation of vagus nerve increases the parasympathetic output to the heart and lowers the heart rate. Vagal maneuvers include Valsalva maneuver and carotid sinus massage. Sinus bradycardia can be asymptomatic if it's mild. It's worth noting that all signs and symptoms of bradyarrhythmias, including those of sinus bradycardia, are caused by decreased cardiac output and oxygen delivery to the body. Patients may experience fatigue, shortness of breath, lightheadedness and exercise intolerance. Ischemic chest pain can occur in cases of severe sinus bradycardia. This is because decreased cardiac output causes decreased coronary perfusion and myocardial oxygen deprivation. Syncope may occur in cases of sinus bradycardia due to sudden severe drop in cerebral perfusion. Diagnosis of sinus bradycardia is based on the combination of the patient's symptoms and ECG findings. Electrocardiography will show heart rate less than 60 beats per minute with no other ECG abnormalities. The fact that there are no other ECG abnormalities in sinus bradycardia is very high yield because this is how we differentiate it from other bradyarrhythmias. We should also inquire about the medication history to check if patient is taking beta blockers or calcium channel blockers. Measuring serum TSH levels will help us rule out hypothyroidism as a cause of sinus bradycardia. This is what ECG looks like in the patient with sinus bradycardia. In case of regular heart rate, we can calculate the rate by dividing 300 by the number of big boxes between neighboring R waves. In this ECG, we can see that there are 7 big boxes between neighboring R waves. Therefore, this patient's heart rate is around 43 beats per minute. Let's talk about the management of sinus bradycardia. Mild and asymptomatic cases need no treatment. In contrast, if the patient is symptomatic, one can administer atropine, which will increase the heart rate. Temporary or permanent pacemaker may be necessary depending on the duration of sinus bradycardia. Additionally, we should either discontinue or lower dosage of SA nodal blocking agents like beta blockers and calcium channel blockers. Hypothyroid patients, on the other hand, should be supplemented with levothyroxine. Let's try a question. A 51-year-old woman presents to the physician reporting fatigue, shortness of breath, and 2 episodes of syncope for the past year. She has bowel movements 3 times per week. Physical exam reveals dry skin and brittle nails. ECG shows heart rate of 45 beats per minute with no abnormalities. Which lab test should be ordered to diagnose the underlying cause of this patient's ECG findings? The patient presents with fatigue, shortness of breath, and 2 episodes of syncope for the past year. These symptoms may be caused by decreased cardiac output and oxygen delivery to the body. Decreased cardiac output is more likely given her heart rate of 45 beats per minute, indicating bradycardia. Dry skin, brittle nails, and constipation, evidenced by 3 bowel movements per week, suggest hypothyroidism as the underlying cause of the patient's symptoms. So serum TSH should be ordered to confirm hypothyroidism. Now we'll move on to sick sinus syndrome. We'll discuss definition, causes, clinical presentation, diagnosis, and management of sick sinus syndrome. Sick sinus syndrome represents SA node dysfunction, which is often secondary to age-related fibrosis. It can cause bradycardia as well as supraventricular tachyarrhythmias. The most common cause of sick sinus syndrome is advanced age. As we mentioned on the previous slide, aging can result in fibrosis of the SA node, disrupting its depolarization. Similar to sinus bradycardia, sick sinus syndrome can also be caused by medications which inhibit SA node depolarization. These medications include beta blockers and non-dihydropyridine calcium channel blockers. Hypothyroidism can also induce sick sinus syndrome due to decreased sympathetic tone to the heart. As we already explained, all signs and symptoms of bradyarrhythmias, including those of sick sinus syndrome, are caused by decreased cardiac output and oxygen delivery to the body. Patients may experience fatigue, shortness of breath, lightheadedness, and exercise intolerance. Ischemic chest pain can occur in cases of severe sick sinus syndrome due to decreased coronary perfusion. Syncope may occur due to sudden severe drop in cerebral perfusion. As we mentioned previously, sick sinus syndrome can manifest with tachycardia as well. Therefore, the patient may experience palpitations due to tachycardia. Diagnosis of sick sinus syndrome is based on the combination of patient's symptoms and ECG findings. Characteristic ECG findings in sick sinus syndrome include SA node block and SA arrest. SA block is the failure of SA nodal impulse propagation. SA arrest, also known as SA pause, is the dropped SA nodal impulse lasting at least 2 seconds. Interestingly, patients with sick sinus syndrome may also develop supraventricular tachyarrhythmias, most commonly atrial fibrillation. Additionally, we should inquire about the medication history to check if the patient is taking beta blockers or calcium channel blockers. Measuring serum TSH levels will help rule out hypothyroidism as a cause of sick sinus syndrome. This is how SA arrest looks like on ECG. Before we explain the SA arrest, let's take a step back and explain ECG calibration. Each small box on ECG equals 40 milliseconds. Each big box consists of 5 small boxes, and therefore it equals 200 milliseconds. 5 big boxes equal 1 second. We can see that the distance between these two neighboring R waves is more than 10 big boxes, or 2 seconds. Therefore, this phenomenon will be called the SA pause or SA arrest. Asymptomatic patients with incidentally discovered sick sinus syndrome require no treatment. If the patient is symptomatic, then we should determine if he or she is hemodynamically unstable. If the patient is hemodynamically unstable, one should administer atropine, dopamine, or epinephrine, and we should start transcutaneous or transvenous pacing. If the patient is hemodynamically stable, then permanent pacemaker is indicated. A 92-year-old man presents to the physician with shortness of breath and fatigue. He has no history of congestive heart failure, valvular defects, or hypothyroidism. He takes no medications. ECG shows occasional sinus block and sinus arrest. What is the most likely underlying mechanism of the patient's ECG findings? This elderly man presents with shortness of breath and fatigue. His ECG shows occasional sinus block and sinus arrest. Sinus block and sinus arrest are characteristic of sick sinus syndrome. Sick sinus syndrome is most commonly caused by age-related SA nodal fibrosis. Here's a table summarizing everything we discussed in this lecture. Pause the video and take a moment to consider this table. Let's end our lecture with a question. An 83-year-old man is brought to the physician by his wife due to fatigue and shortness of breath for 3 months. He's had 3 episodes of syncope during this time. The patient occasionally feels palpitations as well. He does not smoke, drink alcohol, or use illicit drugs. He has no history of diabetes mellitus, hypertension, myocardial infarction, or heart failure. His vital signs are significant for a heart rate of 44 beats per minute. 24-hour ECG monitoring reveals baseline bradycardia with intermittent tachycardia. Echocardiography shows an ejection fraction of 58%. Which of the following is the best long-term management option for this patient? A. Atropine, B. Epinephrine, C. Transvenous pacing, or D. Pacemaker. This patient presents with fatigue and shortness of breath for 3 months. He's had 3 episodes of syncope during this time. He has no history of diabetes mellitus, hypertension, myocardial infarction, or heart failure. Echocardiography shows an ejection fraction of 58%. His vital signs are significant for a heart rate of 44 beats per minute. Considering his advanced age, the most likely cause of this baseline bradycardia is sick sinus syndrome. 24-hour ECG monitoring reveals baseline bradycardia with intermittent tachycardia. This pattern is known as bradycardia-tachycardia syndrome, which is also seen in sick sinus syndrome. The best long-term management option for a patient with sick sinus syndrome is placement of a pacemaker. Therefore, the correct answer is option D. Here's a slide reminding us of the management of hemodynamically unstable and stable patients with sick sinus syndrome. Let's discuss why other options are incorrect. Option A, atropine. Option B, epinephrine. And option C, transvenous pacing, are used as the initial stabilizing measures for a hemodynamically unstable patient with sick sinus syndrome. This patient, in contrast, is hemodynamically stable. Additionally, none of these treatment measures serve as a long-term management option. And that concludes our lecture on sinus bradycardia and sick sinus syndrome.